Thank you, Dr. Heskin, for inviting me, and thank you, audience. So I want to talk about a couple of different topics now. So when you're treating women with hormones, you have to remember one of those other rare reproductive organs called the brain. And I'm going to talk a little bit from my vantage as a neurobiologist, even though I am also a gynecologist, but most of my research is in neuroendocrinology. So I want to talk about brain health. And hopefully I get this right. Disclosures. So I want to talk about what's known and mostly what's not known about the use of aromatase inhibitors and SERMs in brain health, and show you a little bit of the research that we are doing and others, just to help you think about the topic. So I won't have that many answers, but I think there is a fact. The fact is the brain is a target for sex steroids. And there are several studies now that have found an association between perimenopause, changing hormone levels, an increase in depression, stress, and what is commonly called cognitive fog. And in the SWAN, which is the study of women across the nation at midlife, there was a fourfold increase in major depressive episodes at the time of perimenopause. So this leads to our current hypotheses that hormonal exposures have the potential to be both neuroprotective or to be accelerating brain aging. And I think none of us want our brain to age any faster than it has to. And so we're going to deal with the concept that estrogens actually may promote brain metabolism, synapses, better mood, and cognition. And that progestins might have the opposite effect, and that SERMs and AIs may accelerate brain aging. So I'm not going to have a ton of facts for all of these, and there are lots and lots of little facts on the slides. Please ignore them. That's just to show you that there really is pretty high-powered research behind most of these ideas, even if there isn't complete answers at this time. So I think most OBGYNs know that perimenopause and early menopause is a time of life when women start to report symptoms that are often called soft symptoms, and they're difficult to put into perspective and difficult to treat in many ways because they're not really classical gynecologic complaints. And these include difficulty with word finding, reduced libido, mental fog, as we've talked about, hot flashes and insomnia are more common. But we also have begun to recognize in large population studies that women are at higher risk for neurodegenerative disorders, not all of them, but some of them, including dementia as compared to men, and that early loss of ovarian function or things that would actually masquerade as reduced ovarian function actually have the possibility of accelerating brain aging. So this is a lovely study that is relatively recent, looking at cognition in the perimenopause. And the little asterisks are showing the decrement in verbal learning, verbal memory, fine motor skills, and attention and working memory that's found in the early perimenopause, early menopause transition. So when women actually become hypoestrogenic, these are some of the symptoms that they report. And if you're an OBGYN, these are not really your comfort zone, right? This is not where you spend most of your time thinking what you're going to do. So sound bites that help frame this conversation for me are that not all hormones are the same. So the use of the word estrogen is kind of a big class of hormones, not a specific hormone, and there's a lot of misunderstanding about that. Not all progestins are the same, and not all women are the same. We never have any trouble with that third one, right? Everyone knows that they're all different. But the other concept that's really hard to get across is that hormones are potent, and it's actually a pretty narrow U-shaped curve for risk and benefit. And most of the time, what you see or what you want falls within a pretty narrow range. Now, if you're having trouble with this idea, think insulin. A little too much and a little too little, and you really find yourself in trouble. How many of you have ever overdosed a person with levothyroxine? Have you ever seen someone in thyroid storm? It's not a very good picture. They're not very happy. And really, they only have about a 10 or 20% increase in levothyroxine when you get that kind of a picture. So you really have to get the dose right, and we haven't paid that much attention to doing so. So, and sort of this is my homage to the cellular people in the room. I kind of think of this as balancing the growth versus the atrophy. So you don't want your brain to atrophy, and you want it to grow and renew itself, but you don't want all the cells in your body to have overgrowth. So how can you balance those two? And some of what happens is that cells that are older actually aren't the same, even if they're the same cell type, as when they were younger, because of telomere shortening. And of course, this is the famous group that was headed by Elizabeth Blackburn that won the Nobel Prize for discovering telomerase and telomere length. And the main point, I think you can see right here, is that cells keep dividing if they have long enough telomeres, and what keeps them long is telomerase. And then if they have insufficient telomerase, then they stop dividing, and they develop essentially an atrophic syndrome. So there's been a study or two, all of these are relatively new, trying to look at the relationship between telomere length and telomerase and the brain. And so this was one that's looking at hippocampal volume in early aging. So the hippocampus is the part of the brain that's typically degenerating in Alzheimer's disease and is important for location and memory. So greater exposure to estrogen was associated with an increase in telomere length in this one study, and telomere lengths were longer in women who had used hormones postmenopausally, and low levels of estrogen and obesity were associated with shorter telomere lengths in this study. So that's about as far as people have gotten on a pretty complicated topic. So it's too early to conclude. I mean, I sort of say, and this is intended, keep an open mind, because we're sure what we want to recommend quite yet, but we are sure that hormones have a variety of effects, and these are some of the cellular effects that they have, and we've been talking about those cellular effects as they relate to endometriosis and endometrial cells, but now I'd like you to shift your attention to think for a moment about neurons and other cells in the brain. So behind the background of this slide is 2 neurons, and each neuron will have as many as 10,000 connections with another neuron group. So each neuron can actually connect in 10,000 different ways. And if you think of all the neurons that there are and all the different connections, suddenly you realize that this is an incredibly, I'd say, metabolically active, would not really quite do justice to it, an incredibly active part of the body. And there are a lot of neurotransmitter systems, all of which so far have been shown to be impacted by sex steroids. And these are some of the functions that those neurotransmitter systems mediate. And here are some of the behaviors as well. So we all know that what patients report are their behaviors and their feelings. And what we're thinking about when they're reporting them are what body part is this involving and what can we do about it. So when you think about the complexity, then it's a little intimidating, and I think most people just decide to back off and not think too much about it. Some of us decided to lean in. And one thing that's fascinating about the brain is how much of your daily energy intake it actually requires. So infants require 60% of their daily energy intake for their brain, and humans about 25%. So when you have an animal model and you're studying hormones and it's a rodent, it's really not going to actually let you answer the kinds of questions about brain health that you might want. So the brain is actually 2% by weight, but 25% by oxygen consumption. So this is an argument by analogy. I talked a little bit about getting thyroid hormone levels right, and people who have thyroid cancer have to periodically come off their levothyroxine to look for metastases or expansion of their thyroid cancers. And when they do, people have put them in the neuroimaging machine to ask questions about what the brain is doing. And what you can see is there's a decrease in cerebral blood flow by about 23%, and that's accompanied by a 12% decrement in brain metabolism. And this you can find using positron emission tomography and looking at glucose uptake in brain regions. And you can actually do that task-free or with tasks. So you can give the brain activational tasks and see if the brain can respond to those tasks in the same way before and after a perturbation or an addition of a hormone. So that's what was done here. It was before and after the addition of levothyroxine. And without the levothyroxine, there were complaints that are pretty similar to menopause: depressed, anxious, and psychomotor slow. And those were, of course, corrected. And what's interesting is how few brain centers are impacted for the patients to be symptomatic. So these little spots are actually the brain centers that were different before and after levothyroxine. But that had a very major impact on cerebral blood flow, as well as a major impact on metabolism and behavior. And these are studies looking at women who were taking hormones who were randomized to stop or not. So this was about the time of the WHI, and putting people on hormones at that point was kind of heretical. So instead of doing that, they asked people if they would agree to be randomized to stop or not. And so they came in on their customary hormone cocktail, and then they were asked to either continue or not continued, and then they were studied by PET scan at 1 and 2 years. Very interesting set of studies. I just show you this part here. So hormone users showed relative preservation of frontal and parietal cortical metabolism, and the estradiol users were 3 standard deviations better in verbal performance than Premarin users. It's pretty amazing. And then the E plus P group had lower metabolism than the E alone group. So when you're thinking about the brain, it's pretty hard to do a randomized clinical trial and see if they're going to get Alzheimer's or not, because none of us are going to be around to count the data. So you have to use other pieces of the puzzle to try to figure out what's going on. And lots of different methodologies have been basically utilized to try to address these questions. So some of the questions that we've been trying to answer through a variety of methodologies are whether sex steroids promote plasticity, maintain brain function, and confer neuroprotection. And what are the risks of altering in premenopausal life sex steroid exposures? So just to reorient you, this is a synapse, and it's a pretty metabolically active part of the body. And when you lose about 25% of these delicate little parts of your brain, you start to have mild cognitive impairment. And this is before you can actually be clinically diagnosed. So it takes a while. There's a ceiling effect, if you will, before you start to see the brain malfunction due to a loss of synapses. And this is an animal model. So these are monkeys, and they were ovariectomized, and then some were given back estradiol, and some were necropsied here without estradiol. And this black dots are spines or synapses. So you can see without estradiol, there is a loss of synapses. And the good news is by replacing estradiol for 3 months, you can actually have these synapses regrow. So just keep this in mind. So if you were a human and you had this brain, let me get this, go back. You would probably be faster in your thought processes, and if you had this brain, you would probably be slower, just because your neurons are now not as connected as they once were. And what has been shown so far, and there's very few studies, so if you go out and do the literature search on this, it won't take you too long, is that letrozole exposure actually reduces those spines in the brain. So that's a problem, because this is a drug that's used for lots of different things, and we're talking about it today for breast cancer and as well as for endometriosis. And of course, you know, it's an aromatase inhibitor, and this is a mouse model. So it's going to underestimate probably the impact in humans, but basically, if you look at it, certain parts of the brain are much more sensitive, particularly the hippocampus, which is in fact the part of the brain that falls apart in Alzheimer's disease. And then this is just another study showing the same, but what's interesting about this study, and the reason I put it up there, is that the male mice have a different response to letrozole than do the female mice in terms of spine number. So this is a very female delineated event, and is not seen. And so estradiol actually falls, as shown here, in both the males and the female mice, but in only the female mice do you see the spine number diminish. So estrogen has many, many effects on neurons and the supporting part of the brain, including the glia. And we don't really understand them all, but at least they operate through ER alpha, ER beta, and through membrane receptors, which are shown here. We're not sure all of the ways in which estradiol keeps brain metabolism up, so I can't tell you that we have a complete story, but this is a nice picture to show that there are many mechanisms by which estrogens impact positively the brain. So this is the very first study that was done using a task to ask questions about whether estrogens helped, and this estrogen was conjugated equine estrogen. And these are 60 midlife women, and they're given just a very short exposure to conjugated equine estrogen for 21 days, and the task is reading and understanding what you've read. And when you do that, they read better when they're on estrogen than off. And then they do the neuroimaging studies to accompany this to show that the brain is actually more engaged or activated during the reading task when there's estrogen in the background. And this is a comparison of 17-beta estradiol with conjugated equine estrogen, this time just neuroimaging. And this is another similar kind of study just to show that estradiol in this study increased frontal activation and allowed the brain to tackle more complicated tasks. So there's been not that many of these studies. So when this was done, this review was done in 2014, there had only been 35 studies. That was a sum total of studies in humans looking at hormones and activation. We do know that depressed mood can sometimes masquerade as reduced cognition. And so part of this story that we're trying to understand has to do with what impact hormones have on mood as well as directly on cognition. And again, if you look at these two neurons, I think you get a sense of the complexity. So the blue and the red are just two neurons. And you can imagine how much complexity that confers if there are more neurons than there are stars in the Milky Way, which is in fact true. So this is a brain that's depressed. And this is serotonergic binding in the temporal lobe of a not depressed person. So this is the serotonergic hypothesis of depression, showing that depressed individuals have less serotonergic drive. And this is one of our original studies looking at the impact of 17-beta estradiol at the dose of 80 picogram per ml on recently postmenopausal women's brains and looking at serotonergic binding. And long story short, is doing this region of interest analysis and looking at the frontal lobe, we could see that estradiol plus progesterone restored the brain's serotonergic binding in key cognitive areas and in key emotional areas. And this is a study I think is very interesting to note. So when you are stressed, you have high cortisol, and if you're stressed long enough, you can get depressed. And what's interesting is that cortisol actually interferes with estrogen action in many tissues, including the brain. And just for Dr. Taylor, I'll say that cortisol hijacks the cellular machinery needed for estrogen action. He doesn't like it when I say that. But this is a lovely study by Shannon Worley showing exactly that several hundred genes were co-regulated by both dexamethasone and estradiol in an antagonistic fashion. And if cortisol gets there first, then estrogen action is interdicted. But it's not the same in male and female rats. And so you really have to remember that there are major sex differences, both at the level of the brain and other tissues. And even a simple hormone like cortisol doesn't have the same effects. And this is just looking at gene expression in female rats and male rats. given the same dose of glucocorticoid. But what's even more interesting is when they were given LPS to mimic an infection and cortisol, the male rats lived longer and the female rats died earlier. So cortisol in females actually was pro-inflammatory in this model. And this is another pretty complicated set of studies. I'm just going to focus on the last one, showing that acute stress, shown in green, actually decreases the availability of estrogen-responsive parts of the brain to estrogen. So just the fact that you're stressed actually makes estrogens have a different action in the brain. So again, which hormonal agents are best for brain? And that's a much more complicated question now than one would have thought. And which hormonal agents are worst? And at least in terms of this one review by Pauline Mackey, the worst progestin in her mind is medroxyprogesterone acetate. And I like this slide because it's monkeys and they're easier to blind than humans, and we want to study behavior. So the two behaviors that were studied in this are female sexual initiation and female-to-female antagonism, both of which are important things to understand, I would argue. I hope you would agree. So in this one right here, medroxyprogesterone acetate completely obliterated interest in sex. And in this one, it was wonderful for sustaining female-to-female antagonism. So I had a patient come in one day telling me that she'd been placed on Prempro and that she was telling people on the street how to behave. And she was about 5'1" and 110 pounds, and I said, "This is life-threatening, you need to stop the hormone, or otherwise you may not come to see me again, you may not be live long enough." And we put her on something else. And we sort of triaged her behavior to the top of the pile. Didn't matter what else was going on. This is anxiety and estradiol versus tamoxifen, again in a monkey model, and just showing that if you give placebo to ovariectomized monkeys, they're about this anxious. If you give some estrogen, they're less anxious. If you give tamoxifen, they're more anxious. And if you put the two together, you get something intermediate. And this is a study we started in Pittsburgh looking at early stage breast cancer survivors and looking at brain function. So in the beginning, we actually couldn't do very good MRI, and we started just with a battery of psychometric testing. And this is RN PhD Kathy Bender, who's the PI on the grant. And what she found is that cognitive impairment was more severe and there were more memory domains impacted by women who received tamoxifen as adjuvant therapy versus nothing. And then when people started using more commonly aromatase inhibitors, they were added to the pool. And in her studies, anastrozole was worse than was actually tamoxifen. I got to see these patients clinically because they were part of the STAR trial and they were coming into my office with just an incredible load of complaints, and I had no perspective on how to handle them at the time. And so that's partly how the study got started. And then this is the only study that's ever looked at an aromatase inhibitor and brain function, and it's just after 6 months of exposure. And the women were given tasks and then given 6 months of AI and then given the same tasks again. But what it showed is that in order to perform the same on the tasks, they had to try harder, and there was more brain activation when they were on an AI. And then this is a lovely study in which women with breast cancer were given adjuvant therapy and then stopped it. And then they looked at their cognitive function at the end of 5 years and then after 1 year off adjuvant therapy. And there was an improvement in psychometric performance. So that's a whirlwind of data just to kind of get your feet wet. I know you're not in necessarily the neurobiology world, but I think when you start thinking about it from a mechanistic point of view, it's plausible. There's reasonable data out there to worry about the impact of aromatase inhibitors and SERMs on brain function. And while it doesn't give us hardcore answers, I think it should at least raise questions. So this is a lovely study. This was done in Utah in Cache County, and it's a prospective observational trial of men and women free of disease enrollment at age 65, and they're following them for dementia, all-cause dementia. And you can see that women have much higher rates of all-cause dementia as they age, and that the longer they used any kind of hormone, the lower the risk of dementia. So while hormones won't prevent dementia, they do seem to mitigate the risk. And so we got curious, we're doing studies on neurotrauma. We got curious as to the hormone levels in the CSF, because the bloodstream isn't really where all the action is, at least if you're in neurobiology. And so you may have wondered whether testosterone levels in the bloodstream translated into testosterone levels in the brain. And here they are in men versus women. So they're much higher, but estradiol levels are the same. So after menopause, those levels in women go much lower. So the menopausal brain's not seeing very much at all. And if you give someone aromatase inhibitors, they actually also see less estrogen, right? Because part of the estrogen in the brain comes from the circulation, and part of it is made in the brain, in the glial cells. So if you do an aromatase inhibitor, you're going to take the estrogen away from both sources. And this is an interesting study because people have been all over the map about whether hormones are neurodegenerative or protective. And this is a wonderful study from Finland by Tommi Mikkola. And looking at vascular dementia and Alzheimer's dementia, showing that hormones were helpful and reduced the risk of vascular dementia in his study by 38%, and for Alzheimer's disease, a reduction of 15%. And then this is the Olmsted County, Minnesota studies looking at prophylactic oophorectomy before age 45, showing that women who have this have an increased risk of death, depression, Parkinson's, and all-cause dementia. So I really came here to promote the concept of brain health. And when we're thinking about what to treat women with who have different disorders, including endometriosis, I hope that we will consider in the risk-benefit analysis the brain. There are some information-free zones. I'm going to just show them quickly here. So there's a lot more work to do, and for those of us who like to do that kind of work, that's the good news. And for those of you who want a little summary of what I've just said, I want you to remember that estrogen affects a panoply of different brain functions. So it's pretty hard to wrap your arms around this by measuring just one aspect of brain function, but that estrogens may protect against depression, anxiety, and stress, any of which may masquerade as dementia, and that stress, progestins, a break from hormones, or use of other hormones, pre-existing disease may actually counteract some of the effects of estrogen, which is why the studies, I believe, are so messy in terms of the results. And that at a minimum, and I didn't really show you these data, to get full neuroprotection, you have to occupy ER alpha and ER beta. And it has to get into the brain for it to be fully neuroprotective. So we don't really understand the full effects of SERMs on brain, and not only brain function acutely, but brain function in the future. And at least the preliminary data that we have on aromatase inhibitors doesn't seem to indicate it's very brain friendly. And in one of the studies, those who already had the least brain reserve were actually the most affected by SERMs and AIs. And that, going forward, I hope when we do our studies, we really actually include the brain. We have very good methodologies now, particularly it's pretty economical to measure regional cerebral blood flow with a PET scan. It's not that hard to do, and you can do task activation, and you can actually find out some things about how the brain is functioning when it's under the influence of different hormonal preparations. And I thank you for your attention.